All right, hello everyone. Today we will be continuing with the nervous system, chapter 11. All right, as always, some roots, prefixes, and suffixes. Really, the only one that you might know is the first one, cephal, which means head. But we'll talk about some of these. Oh, ganglia. We talked about that one before. A cluster of neuronal cell bodies that lie um, within the peripheral nervous system. We'll actually talk about that one this chapter. You might have heard of meningitis. We'll talk about the three meninges of the brain and spinal cord this chapter. All right, so central nervous system. We know that it makes up the brain and spinal cord. Obviously, the brain is the most complex, largest portion of the nervous system. We also know that the brain controls sensation. We know that the sensory neurons bring information, or that afferent pathway brings information to the spinal cord and the brain for processing. And also, brain does perception, controls movement, thinking. The brain is divided into two cerebral hemispheres, the left and the right cerebral hemispheres. Those are the big portions of the brain, like the frontal lobe, parietal lobe, temporal lobe, occipital lobe. And depending on what textbook you look at, the brain can be classified in different ways. This textbook will classify the brain by the cerebral hemispheres, the diencephalon, brainstem, and the cerebellum. So that's what we'll be bringing the brain down into. So for the brainstem actually connects the brain to the spinal cord. We'll see pictures of this later on. And then the brain and spinal cord will connect to the peripheral nervous system by way of the peripheral nerves. And then we also have the meninges, which we will talk about on the next few slides. Meninges are just membranes that protect the brain and spinal cord. There's three meninges, and they just lie between the bone and soft tissue of the nervous system. So there's three layers, and I just remember them from outer to inner. We have the dura mater. It's M-A-T-E-R, not M-A-T-T-E-R. So the outer layer is the dura mater. And then I'll just show you the dura, arachnoid, and pia mater. So I just remember DAP, D-A-P, dura, arachnoid, pia. So the dura mater is that outer layer. It's very tough. It's made up of dense connective tissue. It has these dural sinuses. We call them dural sinuses because they're in that dura mater. Has some blood in it, venous blood, not arterial blood, but venous blood. And there's this space. So sinuses is basically a space. So we have this epidural space. So if you have an epidural catheter for females that are, going through childbirth, you might have an epidural catheter. So this epidural catheter, epi means around. So this epidural catheter would go just outside of that dural space. So you would not puncture that dura mater when you're placing this epidural space or this epidural catheter. So loose connective tissue, blood vessels, some adipose tissue, which is just fat. And then we have this subdural space. So sub means under. So you would this is just underneath that dura mater. So if you've have ever heard of like a subdural hematoma, you actually have like a brain bleed right underneath that dura space. So this space is underneath that dura mater. So it's between the dura mater and that arachnoid mater. So then we have the arachnoid mater. That's that second layer of meningeal space or that matter. It's that middle layer. It's actually kind of spider webby looking. It's like I said, underneath that dura mater. We also have the subarachnoid space. So underneath that arachnoid mater, and that's where we're going to find the cerebrospinal fluid. So if you've ever had like a lumbar puncture, to where you have to have like some cerebrospinal fluid removed from for testing. The physician or nurse anesthetist would remove the cerebrospinal fluid from the subarachnoid space underneath the arachnoid mater. And then that third layer is the pia mater. It's that inner layer. It's actually attached to the surface of the brain and spinal cord. And it contains a lot of blood vessels and nerves. It's actually what nourishes the central nervous system. And you can see the picture down here. There's your three meningeal layers here. Your dura mater is that outermost layer, and then that arachnoid mater is here, kind of like in pink, and then we have our cerebrospinal fluid, and that pia mater is that I guess orangish, pinkish looking color, or peach looking color. Meningitis. So we can have bacterial meningitis or viral meningitis. Itis means inflammation of. So meningitis is just an inflammation of one of those meningeal layers. And they can be just inflamed, swollen. So that's just what meningitis is. All right, so here's just another picture of the dura mater, arachnoid mater, and pia mater. So here's your dura mater. So here's some adipose tissue that I was talking about. So you would place your epidural catheter kind of right here outside of the dura mater. Then we have that subdural space, which would be right here. So if we were looking at the brain, this would be where the subdural hematoma would be. Then you would have your cerebrospinal fluid here. So that's your subarachnoid space. And then your pia mater. Remember, your pia mater just kind of is glued to the brain and spinal cord. So you really can't you kind of really can't place anything. There's really no sub-pia space. So if you're doing dissection of the brain or the spinal cord, you'd have to really kind of tear off that pia mater. And like I said, it's kind of glued to the brain and spinal cord. So it's really hard to tear away that pia mater. All right, so cerebrospinal fluid. I mentioned before that we have 4 ventricles in the brain that contain cerebrospinal fluid. And these ventricles are continuous with this central canal of the spinal cord. And continuous just means that it's kind of free flowing with this central canal. There's no stops between these ventricles and the spinal cord. So we call these ventricles essentially the first, second, third, and fourth ventricle. These first two ventricles are actually called the lateral ventricles. And most of the cerebral spinal fluid is actually produced in those first two lateral ventricles. It's secreted by this structure called the choroid plexus. And then from the first two ventricles, or those lateral ventricles, it goes through this structure called this interventricular foramina. Foramina just means kind of like a hole. So this interventricular foramina, inter kind of means between, so between the ventricles, or the hole between the ventricles, would connect those lateral ventricles to that third ventricle. So the cerebral spinal fluid goes from those two lateral ventricles through that interventricular foramina to that third ventricle. And you can kind of see, so there's your two lateral ventricles. Then you have your interventricular foramina, kind of like here. Then you have your third ventricle. It's actually located in this structure called the diencephalon. We'll look at the diencephalon later on. And then we have this structure called the cerebral aqueduct. And that's going to connect that third ventricle to the fourth ventricle. And that fourth ventricle is actually located in the brainstem down here. So the fourth ventricle is located in the brainstem, and then from there, the cerebral spinal fluid can go down from the brain into the spinal cord. All right, so cerebral spinal fluid. Like I said, it's secreted by this structure called the choroid plexus, singular, or choroid plexuses, which would be plural. And basically, these are essentially capillaries of the pia mater. Remember, pia mater is that inner layer of the meninges covered by these things called ependymal cells. We briefly mentioned ependymal cells last chapter. Cerebral spinal fluid should be clear and watery. So kind of essentially looks like water. We have about 140 milliliters of cerebral spinal fluid at any given time. The cerebral spinal fluid does go back to the blood, kind of once it gets, or go back to the cardiovascular system, the bloodstream, once it kind of gets dirty and needs replenishing. Basically, cerebrospinal fluid is it provides the nutrients and protection of those central nervous system neurons. So it helps maintain that ionic concentration within the central nervous system. We still need that the proper amount of sodium and potassium and all of those ions, glucose. Remember that I said, when we talked in chapter 4 about, glycolysis and citric acid cycle and all that stuff. And typically we use glucose for metabolism and cellular respiration. But we can use fats and we can use proteins to kind of enter in that citric acid cycle to be used for energy. What's different about the central nervous system is that the central nervous system must use glucose for energy. So the central nervous system has to have a continuous supply of, excuse me, I got the hiccups. The central nervous system must have a continuous supply of glucose in order for it to use energy. All right, so we've already said that that CSF, cerebral spinal fluid, circulates in those four ventricles down through that central canal of the spinal cord, um, throughout that subarachnoid space. So between that arachnoid matter and that pia matter, and after it exchanges all of those ions, um, it will, become a little bit dirty, and then that cerebral spinal fluid has to go back in that cardiovascular system, and into the blood. And it's actually absorbed back into the cardiovascular system by these things called, these structures called arachnoid granulations. So you can see up here these structures called arachnoid granulations. And that's how cerebrospinal fluid gets back into the bloodstream. All right, so traumatic brain injuries. We call those TBIs. Traumatic brain injuries are usually a result of like falls, an attack, accidents, sports injuries. We have concussions. Concussions are a mild form of a traumatic brain injury. Typically, concussion, one-time injury, your brain gets bruised, and typically there are no long-lasting symptoms. And usually you rest and your brain heals. Now, one of the things that we're finding is that you really should not be on things that produce blue light, such as computer screens and cell phones, for about 7 to 10 days following a concussion, because blue light will actually not let your brain heal. And I don't know about you, but I don't know if I could live without my cell phone for 7 to 10 days. But concussions usually heal as long as you let your body rest. Now, with sports related injuries, what we're seeing now is this pathology called chronic traumatic encephalopathy, or CTE. And back in the 80s and 90s, high impact sports, football, hockey, rugby, we didn't know a lot about concussions, and we would send these players from the high impact sports back into the field of play. Grow up, be a man, get back in there and play. A concussion's not that bad. We didn't have those concussion protocols like we do now. So a person would have, or a player would get hit very hard, and they would have a concussion. We would send them back into play, and they would get a concussion on top of concussion on top of concussion. We would not let them heal from that original concussion, and they would get, like I said, concussion on top of concussion on top of concussion. And now what we're finding is early onset dementia, early onset Alzheimer's, and so now we're kind of changing the padding of these high impact sports. We're changing the rules of the game, how hard you can hit, where you can hit. And it's because of these small injuries over time are actually building up, and the effects of those small injuries are actually multiplying. And the effects of those small injuries are actually creating one, large injury. So these symptoms actually begin later, and they're actually having very long-lasting effects on memory and behavior. Like I said, early onset Alzheimer's, early onset dementia. Another one, blast injuries. severe traumatic brain injuries, typically seen in the military, explosions from combat injuries. Those often lead to cognitive decline years after injury. We don't see those the effects of those injuries right away. All right, a cerebrovascular accident, also called a stroke, basically is death of nervous system tissue due to blocked blood flow. So we actually have two types of strokes or cerebrovascular accidents. One is called an ischemic stroke. This is due to a blocked blood vessel. Typically, let's say you have a clot let's say you have a clot down in your leg. That's called a thrombus, and that clot has dislodged. Once a clot dislodges, that's called an embolus, and that embolus then travels up into your brain and blocks the blood flow. So now you have an ischemic area in your brain, because that clot or that embolus now is blocking the blood flow past where that clot is. And then your brain tissue starts to die because it doesn't have that blood flow. The other type of stroke is called a hemorrhagic stroke, where a blood vessel in your brain actually ruptures. So we have this mnemonic called FASTER. It used to be called FAST, but there's different mnemonics out there. FAST, FASTER. One is called BFAST, but FASTER. So look at your face, or look at someone's face. Do they have an uneven smile? Typically, one side of the face droops or is numb. Look at their arms. When you hold your arms out and their eyes are closed, maybe one arm kind of droops down, or one arm is weaker, or is more numb than the other. Look at their stability. Are they dizzy? Do they have a hard time keeping their balance? Do they have trouble walking? Is there a loss of coordination? How are they talking? Do they slur their words? Are they unable to speak? Do they have a hard time being understood? Or do they have a hard time understanding speech? What are their eyes doing? Do they have difficulty seeing out of one or both eyes? Do they have double vision? Whatever the case, react. Call 911 immediately, even if their symptoms go away. The important thing to remember is that you need to tell 911 or the physician when the symptoms started. Because every hospital has a protocol of when they can give, if it's a hemorrhagic stroke, when they can give that clot buster. And you can only give that clot buster within a certain amount of time after the symptoms started. So, let's say your symptoms started, yesterday at noon, and now it's 24 hours later. It's going to be too late to do anything. But if the symptoms started, 2 hours ago, it's still within that window of time. So remember when those symptoms started. And typically, a stroke is going to affect the frontal lobe. So if you look at where these symptoms are happening, that typically is going to be those symptoms are in the frontal lobe. All right, cerebrospinal fluid pressure. We can actually measure the pressure within your spinal cord or within your brain. So remember that that we have the area in the brain, the choroid plexus, or that choroid plexuses, plural, that produce or secretes that cerebrospinal fluid, and it's stored in those lateral ventricles, the third ventricle and the fourth ventricle, and in the spinal column, or that central canal of the spinal column. So it's continuously secreted, and it's continuously reabsorbed by those arachnoid granulations. And it can actually, you might have a blockage in the arachnoid granulations or in that interventricular foramina, and that pressure can actually build up. Or let's say that you have an infection in your blood, in your brain. You have meningitis, or if you have a blood clot or a tumor, anything can increase your intracranial pressure. We abbreviate that as ICP. Anything can increase your intracranial pressure in your brain or in the ventricles of your brain. And that can lead to a collapse of your blood vessels in your brain, which could lead to, a stroke, an ischemic stroke, because you don't have blood flow past those blood vessels. Or more serious case, if you have too much pressure built up. Remember, your brain is enclosed in your skull. And I mentioned this several chapters ago. Your brain is enclosed in your skull. And the only way for your brain to relieve that pressure is to go out that foramen magnum, which is the hole that's in your base of the skull that your spinal cord goes out. If you keep increasing that pressure and keep increasing that pressure and increasing that pressure, your brain will actually herniate and go out through the base of your skull. And that's essentially death. But, if you start to have increased intracranial pressure, we could actually, and like I said, we can actually monitor your intracranial pressure. We could actually do a lumbar puncture to actually drain some of that cerebrospinal fluid to help relieve some of that pressure. And we have this condition called hydrocephalus. This is more of a genetic or more of a embryonic or fetal disease or condition where inside the womb, the baby can't get rid of that cerebrospinal fluid, and the baby's head is typically abnormally large. Hydrocephalus, hydro means water, cephal means head. So we kind of say water on the brain, even though it's, cerebrospinal fluid, excess cerebrospinal fluid that can't drain. So babies typically born with a big head, some cognitive delays. But what we can do is we can actually insert this shunt, which would go into the head, and we tunnel that shunt down into their abdomen. And we can drain the cerebrospinal fluid from the head down into the abdomen. And then that cerebrospinal fluid would get reabsorbed in the abdomen. So here's just a picture of a lumbar puncture. Here's your picture of your lumbar vertebrae. Here's the end of your spinal cord. Your spinal cord, we'll talk about it, ends around L1. So there's your, L2, L3, L4, L5. So there's your L5, L4. So this lumbar puncture is going in between L4 and L5. And remember, we're in that subarachnoid space because that's where your cerebral spinal fluid is. And this picture on the right is just showing normal ventricles versus ventricles that have excess cerebral spinal fluid. All right, moving on. So, really, I think you all know this already. Brain, what does the brain do? Obviously, neural centers for sensory function. We have sensory neurons, those afferent pathways that bring information to the brain. Sensation, perception, the brain controls, how we perceive things, provides that motor output for skeletal muscles, higher mental functions, memory, reasoning, coordinating muscle movements, regulating visceral activity. So visceral kind of just means inside activities, things that we don't have control over. Heart rate, blood pressure, digestion, all of our glands. Also, if you have a personality, your brain would do that. If you don't have a personality, go get one. All right, so this isn't an embryonic class. This isn't a genetics class. We're not going to spend much time on this. But in the womb, we have this thing called a neural tube, which is eventually going to become the central nervous system. And this neural tube forms, or the brain forms from these three cavities or these three vesicles. Eventually, to start out, we have this forebrain, midbrain, and hindbrain. We have this neural tube, and we have this forebrain, midbrain, hindbrain called the prosencephalon, mesencephalon, and the rhombencephalon. And then eventually this cavity will divide into five different cavities. That forebrain will go into the telencephalon, diencephalon. The mesencephalon will stay the same. The hindbrain divides into the metencephalon and the myelencephalon. Again, just listen. You really don't have to know what I'm saying so far. And then those five cavities will kind of divide a little bit into these ventricles and tubes. What you do need to know is that forebrain will become the cerebrum, basal nuclei, and that diencephalon. The mesencephalon remains as the midbrain, and the hindbrain becomes the cerebellum, pons, and medulla oblongata, which will make sense if you know something about the brain. So the forebrain becomes the cerebrum. That is your frontal lobe, parietal lobe, occipital lobe, temporal lobe. Your basal nuclei, the diencephalon, those are your deep brain structures located in the cerebrum. So your forebrain becomes that big part of your brain. Then the hindbrain, which is obviously in the back, that would become the cerebellum. And I'll just show you a picture of the cerebellum. That's down here. Pons and medulla oblongata. The pons is right here, and the medulla oblongata is right here. So, forebrain becomes the cerebrum, basal nuclei, and diencephalon. So here's your cerebrum. Here's your diencephalon. This kind of like these conglomeration of structures right here. All right. So here's just a summary slide of kind of what everything does, or where everything is from that kind of genetics class or the embryology class that we just went over. I really wouldn't worry about this slide too much. Just know the underlying information here. I believe all of you had this when you took your intro psych class. I know I did when I took that intro psych class. All right, so major portions of the brain. So like I said, this textbook divides the brain into the cerebrum, diencephalon, cerebellum, and brainstem. Cerebrum is the big portion of the brain. The diencephalon are kind of like these structures here. The cerebellum is down here, and the brainstem would be these structures down here, midbrain, pons, and medulla oblongata. All right, so cerebrum, biggest part of the brain. All of your lobes of the brain. We actually divide the brain or divide that cerebrum into two halves. We call those the hemispheres, the cerebral hemispheres. It's actually separated by this structure called the falx cerebri. It's actually not shown on this picture because you would have to kind of like dissect the brain down and open it up. It's actually a folded portion of this dural matter. So it might be up here. There it is, right here, this falx cerebri. So right here. That would separate the left and right cerebral hemispheres. All right, we also have this structure called the corpus callosum. That actually connects the cerebral hemispheres. Let's see if I can, right here, corpus callosum. So that's this structure right here. So a lot of your neural pathways will go through the corpus callosum to connect that left and right hemisphere of the brain. All right, so when we're looking at the brain, we have these things called gyri. That's plural. A gyrus is singular. Those are the ridges or convolutions. So they're almost like a raised surface. So here you can see these gyrus or gyri. Those are the raised surfaces. So those are the gyri or the gyrus. We also have these sulci. Those are shallow grooves. So there's a shallow groove, there's a shallow groove, there's a shallow groove, there's a shallow groove, there's a shallow groove. We also have fissures. Fissures would be a deep sulcus or a deep groove. So for example, we have the longitudinal fissure. That's a deep groove. We also, you really can't see it here, but we have another fissure right here that separates the cerebrum from the cerebellum. It's called the transverse fissure. Again, you really can't see it, but it's right there. So know the difference between a gyrus, a sulcus, and a fissure. All right, so the lobes of the brain. So we talked about the bones of the skull. The lobes of the brain fall underneath the bones of the skull, and that's what they're named for. So the frontal bone, frontal lobe, parietal lobe, temporal lobe, occipital bone, occipital lobe. Here is your frontal lobe, parietal lobe, temporal lobe, and occipital lobe. Now we also have this fifth lobe of the brain. It's called the insula or Isle of Rayleigh. It's kind of buried deep within this lateral sulcus. Lateral sulcus is this, remember a sulcus is a shallow groove. So it's kind of buried, this Isle of Rayleigh, it's kind of buried deep underneath here. We won't touch on this Isle of Rayleigh too much. We will a little bit later on. All right, so we have this area called the cerebral cortex. And it's this thin layer of gray matter, and it makes up the outermost layer of all lobes of the cerebrum. So remember difference between gray matter and white matter. So down here, we have white matter of the cerebrum as well. So remember the difference between gray matter and white matter. Remember myelinated axons versus unmyelinated axons. Unmyelinated axons appear gray under the microscope. Myelinated axons appear white under the microscope. So this thin layer of gray matter is unmyelinated axons. So these unmyelinated axons, this thin layer of gray matter, it makes up most of the outer layer of all lobes of the cerebrum. And it says it contains almost 75% of the neuronal cell bodies in the nervous system. Not the central nervous system, but the nervous system as a whole. So just kind of think about that. 75% of the neuronal cell bodies in the nervous system. So a lot of neuronal synapses in this thin layer of the brain. All right, white matter of the cerebrum lies underneath that cerebral cortex. Makes up most of the cerebrum, and it contains a lot of those myelinated axons, hence white matter, and it connects cell bodies in that cerebral cortex to other parts of the nervous system. All right, so this cerebral cortex has this really thin layer of gray matter and a bunch of white matter. So remember here in this thin layer that contains about 75% of the neuronal cell bodies in the nervous system. That's a lot. All right, moving on. All right, so the cerebral cortex, what does it do? A lot of higher mental functions. So it interprets those impulses from your sensory organs. It initiates a lot of your voluntary movements, so a lot of your skeletal muscles. It stores your information as memories. It retrieves stored information, reasoning, intelligence, personality. Now, we've done a lot in mapping the brain, but we really still don't know a lot about the brain. And we know what the frontal lobe does. We know what the temporal lobe. We know what the parietal lobe does. We know what the occipital lobe does. But that we can't say, oh, this is where this starts and this is where this stops. This is where this starts. This is where this stops. So we don't have a defining start-stop areas in the brain. So we classify the cerebral cortex into kind of sensory areas, motor areas, and the association areas. And they overlap because, like I said, we don't know where things start and stop. And each area contains neurons that work together to perform all of these functions. So we have the frontal lobe, temporal lobe, parietal lobe, occipital lobe. And we'll go through what each of the lobes do. And we'll come back to the slide in a little bit. All right, so for some of the sensory areas, we have this cutaneous sensory area. Cutaneous, remember, means skin. It's located in the parietal lobe. So because it's skin, it interprets sensation on the skin. Remember, we're talking about sensory areas right now. So these sensory areas. Sensory area for speech. We actually call that the Wernicke's area. That's right here. So right here. It's partly in the temporal lobe, partly in the parietal lobe. It's usually in the left hemisphere, and we'll get to that later on. Understanding, formulating language, hence speech. The visual sensory area, occipital lobe, it interprets vision. Remember, sensory area. There really is no motor component to interpreting vision. Auditory area, that's your hearing. It's in your temporal lobe. Makes sense because your ears are here. So your temporal lobe is right next to your ear. The only one that I don't understand is if your eyes are in the front of your head, why is your vision processed in the back of your head? That's the only one that I don't understand. All right. Sensory area for taste. Near the base of that central sulcus, that's your Isle of Rail, your insula. Remember, it's buried deep within that lateral sulcus and that central sulcus. Sensory area for smell. There's no motor component to smell. You're only sensing those chemicals that you smell. Again, temporal lobe. Your nose is here, so it's processed in your temporal lobe. All right, motor areas of the cortex. So now we're talking about motor function, movement. Frontal lobe, that precentral gyrus, which we'll talk about this precentral gyrus and the postcentral gyrus here later on. Motor component controls voluntary muscles, a lot of your skeletal system. And it says most nerve fibers cross over in the brainstem. And I'm sure you know that the right side of the body controls the left side of the brain. The left side of the brain controls the right side of the body. So at some point, these nerve fibers will cross over either in the spinal cord or in the brain. But here, these nerve fibers actually cross over in the brainstem, not in the spinal cord. Broca's area. Broca's area, again, is in the primary motor cortex, which we'll see a picture of here in a couple slides. Usually in the left hemisphere, which, like I said, I'll get to the usually portion later on. Controls the muscles needed for speech. Again, we're talking about motor component. Broca's area is right here. So again, speech. We have Wernicke's area and we have Broca's area. So speech perception is Wernicke's area and the motor component is going to be Broca's area. All right, frontal eye field. It's going to be above Broca's area. That's your motor component for your eyes and eyelids. We'll talk about the cranial nerves 3, 4, and 6. Cranial nerve 3 is oculomotor nerve. Cranial nerve 4 is your trochlear nerve. Cranial nerve 6 is the abducens nerve. You're going to have to memorize the cranial nerves, which we'll go over. All right, so Broca's area, damage to the Broca's area. What's going to happen? Well, first, what does Broca's area do? Controls muscles needed for speech. So, not memory loss. Loss of motor control needed for speech. Impaired motor control for the left-sided body, vision loss. So that's going to be our answer. All right, so I said that we'd get to the, when I talked about this primary motor cortex and that precentral gyrus, and that we have these sensory area. So we have these motor and sensory areas of the cortex. So we have this thing called a central sulcus, which is right here. Remember the definition of a sulcus is a shallow groove. So there's our central sulcus, and this is the anterior portion of our brain, and this is the posterior portion. So this would be the front of the body up here, and this is the back of the body back here. So the anterior to that central sulcus, or towards the front, we have what's called the motor area of the cerebral cortex. And posterior to that central sulcus, we have that sensory area of the cerebral cortex. And what we see is that as we kind of go around these two areas, you can see that they kind of mirror each other. You know, there's the legs, there's the foot and toes, there's the foot and toes, upper face, things that have to do with the mouth, the forearm, the trunk, pelvis. So they kind of mirror each other as we go around the brain. So this is the area of the cerebral cortex that does the motor and sensory areas, and it's located anterior and posterior to the central sulcus. All right, association areas of the cortex. These are regions that really aren't necessarily motor or necessarily sensory, but they do connect to each other and with other structures in the brain. So they're kind of widespread throughout the cerebral cortex. They help analyze, interpret our sensory experience. So they're more like memory, reasoning, verbalization, judgment, emotions. They're not necessarily isolated into certain areas, like here where we can say, oh, this is Wernicke's area, this is Broca's area, or your frontal eye field, or that auditory area. So these are kind of dispersed throughout different lobes of the brain, but not isolated to a specific area within that lobe. So within the frontal lobe, we know that the frontal lobe does concentration, planning, complex problem solving, like higher intellectual processes, emotional behavior, judging consequences of behavior. Now, one thing that we know is that the frontal lobe is not fully developed until about 25 years of age. And one of the things that people or protesters or people keep questioning is that if your frontal lobe isn't fully developed until 25 years of age, why are we convicting people as an adult when they're 18 years old? Your parietal lobe. So think about what the parietal lobe does, or where the parietal lobe is. Understanding speech. How do we choose the words to express our thoughts and feelings? All right, temporal lobe, association areas, interpreting those sensory experiences, understanding speech, reading, where we store memories for visual scenes. We watch a movie, we listen to music, complex patterns. Occipital lobe. Remember, occipital lobe does vision. So how do we analyze and combine those visual images with other sensory experiences? And then finally, that insula, or that Isle of Rail, translating those sensory information into emotional responses. All right, which lobe of the brain are you using when you answer this question? So I would argue that there's two answers. So basically, the book says frontal lobe because you're thinking about, you're concentrating, you're complex problem solving, you're using higher intellectual processes to answer this question. So the book says frontal lobe, which is probably the more correct answer. But I would argue that you're also using your occipital lobe as well, because you're actually looking, you're reading, you're using visual images to read the words. So I would say the frontal lobe is probably the more correct answer, but you could argue occipital lobe as well. All right. Just a summary slide of what everything does. All right, hemisphere dominance. The left hemisphere is dominant in most people. So why is that? Well, I told you already that the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. So most of us are right-handed. So the left side of the body controls the right side of the left side of the brain controls the right side of the body. So that's why the left hemisphere is dominant in most people. So if we go back up to this slide, Wernicke's area, Broca's area, the auditory area, the frontal eye field is going to be predominantly on the left side in most people. Now, if you're left-handed, all of these areas will probably be on the right side of your brain. Because you are left-handed, then your right side of the brain will be dominant. So these areas will probably be on the right side of your brain. Now, what I say for in dominant, the dominant hemisphere control, what I say is that the dominant hemisphere makes you a person. So in order to be a person, you have to have language skills of reading, writing, speech. You have to be able to be verbal, analytical. You have to have some computational skills. And then your non-dominant hemisphere, I say, makes you a well-rounded person. You have to have nonverbal skills. You have to be able to look at things from outside the box. You have to be able to look at orientation in space. You have to be able to understand. You have to be able to interpret different visual patterns. You have to be able to look at things emotionally and intuitive. You have to have those thought processes. So I say that, your dominant hemisphere makes you a person, and that your non-dominant hemisphere makes you a well-rounded person. And then again, your left side of your brain controls or receives impulses from the right side of the body, and your right side of the brain receives impulses and controls the left side of the body. All right, short-term versus long-term memory. We actually have more types of memory than just short-term and long-term. However, we're just going to talk about short-term and long-term memory. Short-term memory, we actually call this working memory. Basically, these circuits are stimulated over and over. And when those impulses cease, so does that memory. Unless we convert that short-term memory into long-term memory. And we do this by a process called memory consolidation. And so if you are at a group function and you meet someone, they introduce themselves, they tell you their name. If you don't practice their name over and over, within 30 minutes, you've forgotten their name. Long-term memory actually obviously holds more memory than short-term, and it's going to last a lifetime. However, it doesn't necessarily last a lifetime unless you still keep practicing. What happens is we change the structure or the function of neuron. We actually create new neuronal pathways. We make new synaptic connections. We increase the branching of those neuronal processes. We increase the neurotransmitter release, and we increase the effectiveness of those neuronal synaptic transmissions because we have repeated stimulation. We've practiced that information. So that's why we tell you, you should study your notes every day. You should practice, if you were forced to take piano lessons, you have to practice the piano every day. You need to practice your notes over and over in order to convert it from short-term to long-term memory. So studying the night before the exam, it's proven over and over again that you don't retain the information. And especially with A&P, you have to know this information to carry on into A&P2. And so many times you get to A&P2 and it's deer in the headlights. And it's like, I know we talked about this in A&P1. And people don't remember it because they cram for the test and they just, they try and hold it in their short-term memory. They dump it out on the exam and then they forget about it. All right, so also the value of a memory is determined by the structure in the brain called the amygdala. Now, the amygdala it's a structure that really hasn't changed over time. It really hasn't evolved. It's also it's a very primitive structure, and so it's like, why do I remember my driver's license number when I lived in Indiana, you know, growing up? But I can't remember what I had for breakfast yesterday. Uh, why did my amygdala choose to remember that? Why do I remember certain things but not other things? Well, apparently my amygdala thought that I needed to remember my driver's license number. All right, I just threw this in here talking about studying and cramming for exams. This guy named Edgar Dale came up with this. We remember 10% of what we read, 20% of what we hear, 30% of what we see, 50% of what we see and hear, 70% of what we discuss with others, 80% of what we personally experience, and 95% of what we teach others. So when I teach or when I learn information, I have to learn it up here in order to teach it to you guys. And so oftentimes students ask, how do I study? I don't know how to study. Some students will, just memorize the underlying information, and that'll get you about, a 50 to a 60% on the exam. Some students, really want to do well in the class, and they say, well, what would you suggest? And we know that the more senses that you use, sight, sound, taste, touch, obviously don't taste your notes, but the more senses that you use, the better you're going to remember the information. So, take the notes, rewrite them in your own words, and then read them out loud. And also use your finger to underline to go and read them, or as you're reading them, underlining them, or read them. Use your finger to move as you read them. So now you're using your sight. You're hearing your notes. You have that tactile stimulation as you're moving your finger. Discuss with another person. So, and then, pretend like you're a tutor. Do what I do, learn it at a higher level. And that's going to allow you to, one, learn the material at a higher level, and get you a better grade. Read the textbook. I actually did a survey in one of my classes 2 years ago, and 85% of the people didn't even look at the textbook. So, some of the questions I don't cover on the exam. You have to read the textbook. So, anyway, so I just thought that this was interesting to kind of point out. All right, so starting off with some of the structures in the brain, basal nuclei. Sometimes we call this the basal ganglia. Remember that the definition of a ganglia is a cluster of neuronal cell bodies in the peripheral nervous system. This is actually the central nervous system, so we really shouldn't call this a ganglia because this is the central nervous system, not the peripheral nervous system. So I would never call this the basal ganglia. I'll always call it the basal nuclei. So the basal nuclei, bunch of gray matter, unmyelinated axons, kind of buried deep within that central, the cerebral hemisphere. You can see the basal nuclei here. It's actually made up of 3 structures called the caudate nucleus, the putamen or putamen, and this globus pallidus. And what it does is it actually produces this compound called dopamine. Dopamine kind of gives you that little high feeling when you ride the roller coaster, but it also helps control voluntary movement, skeletal muscle movement, and It's actually important for Parkinson's disease. Now, we didn't talk about the structure called substantia nigra, but it produces this neurotransmitter dopamine. Substantia nigra also makes up the basal nuclei, but it's not labeled in this picture right here. But the substantia nigra produces dopamine. And in Parkinson's disease, basically the neurons in this substantia nigra degenerate. And therefore, you have less dopamine. And this decreased dopamine, remember dopamine is responsible for voluntary skeletal muscle movement. So you're going to have less dopamine, less motor movement, less motor control. So you're going to see tremors, shuffling gait, rigidity, handwriting issues, speech difficulties. And essentially, with that degeneration, you're going to see an increase in these symptoms. There's really no cure, and you really can't slow down the progression of Parkinson's disease. Now, you can treat Parkinson's with this medication called levodopa or levodopa. It's actually a precursor of dopamine that can cross the blood-brain barrier. And you can have a deep brain stimulator. It's a surgical implant, and that has had some success. But eventually patients will succumb to Parkinson's disease. There is a genetic component to Parkinson's, but it's not directly inherited. But certain drugs and medications, pesticide exposure, and frequent blows to the head can be causes of Parkinson's disease. There's actually a movie from the 90s with Robin Williams called Awakenings. It's a really good movie about Parkinson's disease. If you can find it, I would watch it. Like I said, a really good movie. All right, the diencephalon. Remember, that's between the cerebral hemispheres, and it's above the brainstem. It surrounds that third ventricle of the brain and has a lot of gray matter, so unmyelinated axons. Portions, there's several different structures of that diencephalon. So the thalamus, the hypothalamus, the infundibulum, pituitary gland, your optic tracts, the chiasma, these mammillary bodies, pineal gland. So a lot of these structures right here are the diencephalon. One thing that I will mention, let me erase my ink. So we have this structure here called the pituitary gland. And one thing that I will point out, because it is an exam question, is that the pituitary gland, and here's your hypothalamus. Remember, the hypothalamus controls the majority of your negative feedback loops. But the pituitary hangs off of the hypothalamus by this structure right here called the infundibulum. And you'll have to know that. Pituitary gland hangs down off of the hypothalamus by the infundibulum. All right, so what does the thalamus do? Basically, it's a gateway from taking those sensory impulses and sending them to the cerebral cortex, except for the sense of smell. Your hypothalamus, I've already said, regulates your visceral activities, what goes on inside of your body, your blood glucose level, your thyroid level, your parathyroid hormone, your osteocytes, your osteoclasts, your osteoblasts, all of your or most of your negative feedback loops, heart rate, blood pressure, body temperature, water, electrolyte balances, hunger, body weight, all of these things, those are your negative feedback loops. So it's going to link your endocrine system with your nervous system. It's going to tell your glands when to secrete what. Your limbic system. Your limbic system is actually not really identifiable because there's really no stopping and starting part to your limbic system. We'll see the limbic system in various parts of your brain, including the diencephalon. Your limbic system is responsible for a lot of your emotional responses, feelings, and your behavior towards survival. It's what's responsible for life-threatening situations, whether it be physical or psychological. So a lot of your emotional responses are because of your limbic system. All right, your brainstem connects the brain to the spinal cord. It consists of these three structures: your midbrain, pons, and medulla, or medulla oblongata. All right, so your midbrain is kind of like that topmost portion, or that superior portion of the brainstem. It's between that diencephalon and the pons. So it's going to connect the lower part of your brainstem and the spinal cord with the higher portion of the brain. That's where we find that cerebral aqueduct. Remember, that connects that third and fourth ventricle for cerebral spinal fluid to run through. We also have these cerebral punducles, and that's just basically a motor pathway that connects the cerebrum to the lower portion of the nervous system. Let's see. They're not. Let's see. Well, I'll show you a picture. These are the there we go. Cerebral punducles, right here. All right, we also have this structure called the corpora quadrigemina. And the corpora quadrigemina, basically visual and auditory reflexes. So corpora quadrigemina, right here, visual and auditory reflexes. We also have this red nucleus, basically postural reflexes, helps with your posture. All right, pons. Your pons is basically this bulge on the underside of your brainstem. Here's your pons. It's that bulge on the underside of your brainstem. It basically it's a relay system between the midbrain and the medulla oblongata. It just relays those nerve impulses from the cerebrum to the cerebellum, from that medulla to the cerebrum. But it helps regulate breathing. So if you really want to take out someone, hit them in the pons. All right, medulla oblongata. That's the enlarged continuation of the spinal cord. So down here is your medulla. Again, just a relay system between the brain and spinal cord. cardiac, vasomotor, respiratory control centers, a lot of your reflexes, coughing, sneezing, swallowing, vomiting. Injuries to your medulla are often fatal. So if you want to take out someone, get them in the medulla. All right, reticular activating system or your activation system. Basically, this is hard to isolate. It's kind of scattered throughout the brain or the brain stem into the diencephalon. Basically, it's another connection system of the hypothalamus, that basal nuclei, cerebellum, cerebrum, both ascending and descending, so sensory and motor. Basically, your reticular formation does your wakefulness, your arousal, so your sleep-wake cycle is your reticular formation or that reticular activation system. And if you have decreased activity, that's going to be what makes you fall asleep. And if you have an injury to this area, to the reticular activation system, it can lead to unconsciousness or coma. All right, rapid eye movement versus non-rapid eye movement. Different types of sleep. Obviously, we know we have to sleep. It's very normal, reoccurring. We need that sleep in order to regenerate our body. We need that rest. We have what's called non-rapid eye movement or non-REM sleep, and we have REM sleep, rapid eye movement. Non-REM sleep, that is when we are, we're exhausted. We see that decreased activity in that reticular formation, that reticular activation system. This is where our body is at rest. We don't breathe. We don't dream here. This is where our body is resting. We are regenerating. We are kind of replenishing. We have reduced blood pressure, reduced respiratory rate, reduced heart rate. We have different stages of non-REM sleep. And we go back and forth between non-REM and REM sleep throughout the night. Rapid eye movement sleep is called paradoxal sleep because some of our brain is active. This is where dreams and nightmares occur. Our heart rate is irregular. Our respiratory rate, our blood pressure is irregular because we are dreaming. If we're having a nightmare, our blood pressure, our heart rate would increase. Our respiratory rate would increase. All right, just some disorders associated with sleep. One thing that's interesting, fatal familial insomnia. It's very rare, seen in, I believe it's some Greek population. Basically, you can't sleep. You don't necessarily have an injury to that reticular activating system, but there's something wrong with the reticular activating system. And once diagnosed, death is occurs within about 13 months of onset, usually around the age of 50. We all know insomnia, inability to fall asleep or remain asleep. Narcolepsy, basically, you fall asleep throughout the day. It's not because you didn't get enough sleep the night before. It's just you're doing something and you just fall asleep. Obstructive sleep apnea, typically due to overweight. Being overweight, you snore at night because your tongue falls in the back of your throat. Like I said, typically due to overweight, you might be wearing a CPAP. Restless leg syndrome, sleep paralysis. You wake up and you can't move. And it takes you a few minutes to be able to move after you wake up. You wake up, you're fully aware of what's going on in your surroundings, but you just can't move. All right, cerebellum. Cerebellum, the back of your head. It's inferior or underneath the occipital lobe. So cerebellum down here. Distal to the pons or behind the pons and medulla oblongata. We still have two hemispheres separated by that falx cerebelli. Remember, we had that falx cerebri. It's not pictured here, but we have that falx cerebelli, falx cerebelli, just like we had that falx cerebri. We have a vermis that connects both of those hemispheres. We also have the cerebellar cortex, which is a bunch of gray matter. So this cerebellar cortex right here is a bunch of gray matter. And then we have this it's a bunch of white matter here called the arbor vitae. Arbor means white, or arbor means tree, vitae means life. So a lot of people call this like the tree of life. We have cerebellar punducles, and basically that connects the cerebellum to the rest of the central nervous system. Those are your cerebellar punducles there. We have this dentate nucleus. Basically, the cerebellum takes that sensory information and throws it up to the rest of the central nervous system. It also helps coordinate your voluntary muscle movement, helps maintain posture. All right, just a summary slide of kind of what everything does that we've talked about before. All right, brain waves. So if you've ever had a sleep study done, they'll hook you up to a bunch of monitors and stick electrodes or kind of tape electrodes in your head, and they'll monitor these alpha, beta, theta, and delta waves. Basically, when you're sleeping, they're going to be looking at your delta waves. So really the only thing that you're going to have to memorize from this slide, delta waves are mainly seen during sleep. When you have a sleep study, they're going to do this EEG, electroencephalogram. All right, your spinal cord. Remember, your spinal cord comes off of that brain and brainstem, and it's going to go down through that central canal of the vertebral column. Your spinal cord comes through that hole in the base of your brain. It's called that foramen magnum. I mentioned that a couple times with that brain herniation. Hopefully, we never have a brain herniation. And your spinal cord actually stops or terminates around that first and second lumbar vertebrae, around that L1, L2 space. For your, we have 31 segments of kind of like your spinal cord. And each segment gives rise to a pair of spinal nerves. And those spinal nerves are grouped according to the level of the vertebrae which they are associated. So we know we have cervical vertebrae, thoracic vertebrae, lumbar, sacral, and coccygeal vertebrae. And it says within each group, the pairs of nerves are numbered in sequence from superior to inferior. All right, so let's see. So we'll just do a little exercise here. So how many cervical vertebrae do we have? We have 7 cervical vertebrae. Then we have our thoracics come next. We have 12 thoracics. Then we have, how many lumbars? We have 5 lumbars. Then how many coccygeals do we have? Anyone remember? We have 4 coccygeals, but they're all fused. Oh, I lied. Let me eraser. First we have sacrum. We have 5 sacral vertebrae. Then we have 4 coccygeal vertebrae. Now remember, the sacrums and the coccygeals are all fused into one. So I'll start out with the thoracics. So we have T1, T2, T3, T4, T5, T6, T7, T8, T9, T11, T12. So for thoracics, your T1 vertebrae, your T1 spinal nerve shoots out underneath your T1 vertebrae. Your T2 spinal nerve shoots out underneath your T2 vertebrae. Your T3 spinal nerve shoots out underneath your T3 vertebrae. Your T11 shoots out underneath your T3, your T, so, and so forth. So that's how we name our spinal nerves. And then your sacrum, we still have S1, S2, S3, S4, S5, coccygeal 1, 2, 3, and 4. Obviously, I'm not writing all of those. All right, so for your cervicals, oh, that's not right. Let me not do pen. All right, so cervical vertebrae. We have C1, C2, C3, C4, C5, I'm not going to write C5, C6, and C7. So the difference with your cervicals, we actually have 8 cervical spinal nerves. So your C1 spinal nerve actually jets out above, C2 jets out above, C3 jets out above, C4 jets out above, C5 jets out above, C6 jets out above, C7 jets out above, but C8 jets out below. And then we would start with our T1, and like I said, T1 jets out below. So your cervicals are really the only ones that are different for nomenclature purposes. So those are your spinal nerves. All right, so structure of the spinal cord. When we look at the spinal cord, we can see that there's these enlargements. We have a cervical enlargement. We have a lumbar enlargement. And basically, those enlargements are to allow for nerves to come off of them to supply peripheral nerves to those upper limbs and lower limbs. We also have this thing called a conus medullaris, which is right here. It's kind of like a tapering of that spinal cord. So that's the conus medullaris, that tapering region. Remember, the spinal cord kind of tapers off around that L1, L2 space. We have this thing called a filum terminale. That's down here. It's connective tissue that kind of anchors that spinal cord to the coccyx. Your coccyx is your tailbone. And then we have this thing called a cauda equina. That's basically a bunch of nervous tissue. It's a group of lumbar and sacral nerves. that extend past that L1, L2 space in the vertebral canal. Cauda equina. Cauda means tail, and equina means horse. So some anatomist, when they dissected, thought that this area looked like, or this group of nerves looked like a horse's tail, so that's how they came up with cauda equina. All right, so when we look at the spinal cord, we can do a cross section of the spinal cord, and we can see that the spinal cord has gray matter and white matter. We can see that the white matter actually surrounds this gray matter. So gray matter is kind of in the middle of the spinal cord, and gray matter is in the middle of the spinal cord here, and white matter kind of surrounds the gray matter. And we have this first sentence that says the anterior median fissure and a posterior median sulcus. So we have this anterior median fissure and this posterior median sulcus. So this anterior, remember anterior means towards the front, so that's the front of your body. Posterior means towards the back, so that's the back of your body. And then we have these grooves that extend the whole length of the spinal cord, which they're not pictured here. All right, so white matter surrounds the core of the gray matter. Gray matter is divided into these areas called horns. So you can see this anterior horn, lateral horn, posterior horn. So we have different horns within the gray matter. Gray matter contains interneurons. Remember, interneurons are neurons that relay information within the central nervous system. So all of your interneurons are going to lie within the gray matter. All right, posterior roots contain sensory neurons. Posterior roots contain sensory neurons. So we'll get back to that in a second. Cell bodies are outside the spinal cord in the posterior root ganglia. So here's our posterior root ganglia. So like I said, we'll come back to that in a second. Anterior roots contain motor neurons. So anterior root contains motor neurons. Again, we'll come back to that in a second. All right, so let me erase. Oops. All right, so if you remember our reflex pathway, well, let me do a couple more slides and then we'll, because we'll see this in a few more slides. All right, so two main functions of the spinal cord. We know that there's spinal reflexes, and we know that the spinal cord conducts impulses to and from the brain. So we have what's called a true reflex. They're very automatic, subconscious. We don't know that that's happening. Stimulus within or outside the body. Helps maintain homeostasis. Those are involuntary processes. Heart rate, blood pressure, swallowing, coughing. These are the simplest nerve pathways from a sensory receptor to an effector. Remember that we talked about those. Your receptor, your sensory or your afferent neuron, your interneuron, your efferent pathway or your motor neuron, your effector. A reflex arc. Those are going to be your sensory receptor, two or more neurons, and an effector. Remember, receptor, sensory neuron, interneurons, motor neurons, effector. So we've seen this slide before. Your receptor, sensory afferent pathway, goes to the central nervous system, motor efferent neuron, and then that effector is going to be a muscle or a gland. All right, so this is our reflex arc that you have to memorize. We talked about this before. We have our receptor, then our sensory neuron, our afferent neuron. Now, we go back up to this slide. Remember those posterior roots contain sensory neuron. Those cell bodies are outside the spinal cord in the posterior root ganglia. Those sensory neurons come into the posterior root ganglia where those cell bodies are, and they travel into those that gray matter where they contain those interneurons. So they travel into that posterior horn of the gray matter where they link up with the interneuron, and then that interneuron links up with that efferent neuron or that motor neuron, and that motor neuron leaves through that anterior root. So the anterior root contains motor neurons. So there's our anterior root, which goes down to an effector, which is going to be a muscle or a gland. So you have to know those 5 steps. Receptor, afferent neuron that goes through the posterior ganglia into the posterior root of the spinal cord. Then it links up with an interneuron. Then it goes to the motor neuron or your efferent pathway, which leads out the anterior root to an effector. All right, there's your reflex arc. You have to know that. All right, we also have reflexes that, you go to the doctor's and nurse practitioner office, they bang your knee and your leg goes, you kick your leg up. These are basically used to make sure your nervous system is in working order. Your nervous system is functioning appropriately. We have several different types of your knee jerk reflex is the one that I mentioned, where you extend your lower leg, they tap right underneath your patella. Your plantar jerk, your plantar reflex. The one you have to memorize is a tricep jerk reflex. They're going to hit right here, right above your elbow, and your forearm is going to extend. All right. We have what's called a true reflex, which basically only contains a sensory neuron and a motor neuron. No interneurons are involved whatsoever. You don't have to know this pathway, because remember I said the only pathway you're going to have to remember are those 5 components. Receptor, afferent, interneuron, efferent, effector. But a true reflex like the knee-jerk reflex, those actually only contain two neurons, an afferent neuron and a motor neuron. But like I said, you don't have to know this pathway. Typically, we also have what's called a withdrawal reflex and a crossed extensor reflex. So we have two different types of reflexes. And again, you don't have to know the pathways for these. So, I mean, you can see this crossed extensor reflex and the withdrawal reflex, they're a little bit involved. But what happens is, let's say you step on a tack. Your withdrawal reflex will not only will you raise the foot that you stepped on a tack with. That's the withdrawal reflex. It's called reciprocal innervation. Your same side flexors contract. You pick up your leg. And in addition, those same side extensors, what would normally extend your leg, are inhibited. But also, during that withdrawal reflex, extensors on the opposite side, contralaterally, they are going to contract, meaning that the extensors on the other side of your leg are going to contract so that you don't fall down. You pick up your leg, you pick up your left leg, but your right leg extensors are going to contract so that you don't fall down. And that's the crossed extensor reflex. So if you put your hand on a hot stove, what you'll see is that this arm, your right arm, will contract back, but your left arm would actually push forward because of the crossed extensor reflex. Again, you don't have to know the pathways. All right, we also have ascending and descending tracts that go up into the brain spinal cord and back down again. So ascending tracts, if you think about it, they're going to make sense. Ascending tracts that go into the brain carry sensory information. They go into the brain, so they're going to carry sensory information. Descending tracts, they carry information from the brain back down to the spinal cord and out to the peripheral nervous system. So they're going to carry motor information. So there are ascending tracts that carry information up into the brain from the spinal cord. We have several different ascending tracts. Typically, you're going to be able to recognize these because they have kind of two different names involved in them. Typically, they're going to start with spino something. So they're going to go from the spine to whatever region in the brain. So this first one, we're not going to deal with. So spinothalamic. So this is going to go from the spine to the thalamus. And that's going to conduct impulses from the spinal cord up into the somatosensory region of the thalamus. So your pain impulses, temperature, pressure, touch is going to go from the spine to the thalamus. Your spinocerebellar tract is going to go from the spine to your cerebellum. This is involved in involuntary proprioception. So proprioception is like what are your muscles doing? Your stretch, muscles being stretched. So muscle spindles, Golgi tendon organs, your joint capsules. All right, so what would happen if your right lateral spinothalamic tract is severed? So your spinothalamic tract. So your right lateral spinothalamic tract is severed. So we're going from the spine to the brain. So muscles on the left side of the body would be paralyzed. No, because we're going from the spine to the brain. So this is a sensory component. Answer A is dealing with motor. Pain impulses from the right side of the body would be blocked. No, because remember, the right side of the brain controls the left side of the body, left side of the brain controls the right side of the body. So pain impulses from the left side of the body would be blocked. Yes. Muscles on the right side of the body would be paralyzed. No, that's a motor component. All right, descending tracts, going from the brain to the spinal cord. These are motor components. So typically they would start with something in the brain and ending with spinal. So cortico-spinal tract. So cortico actually means cerebral cortex to the spine. So primary motor cortex to the spine. So that's your voluntary muscle movements. Reticulospinal tract. So you might not know reticulo, but you know spinal, from the brain to the spinal cord. It's actually part of the brainstem. Remember the reticular activating system. Posture control, locomotion, sensory transmission, spinal reflexes. Rubrospinal tract. You don't know what rubro means, but you know spinal, so you know that it starts in the brain and ends in the spinal cord. Controls muscle tone, posture. We have these terms pyramidal, extrapyramidal, extrapyramidal. So kind of look at what pyramidal does versus extrapyramidal. So to answer this question, what are pyramidal cells? So if we go back and kind of look at what where pyramidal and extrapyramidal, where do they originate? What do they do? So basically, pyramidal cells are going to be neurons that originate in that primary motor cortex, and they control skeletal muscles. Pyramidal, primary motor cortex, and control skeletal muscles, voluntary muscle movements. All right. What is the correct order impulses would travel through the brain in a descending motor tract? So now we know that we're going from the brain to the spinal cord. So think about the structures of the brain and where they're located. Would we go from the brain stem to the cerebrum to the spinal cord? No. The cerebrum is the big part of your brain. So logically, we would not go that way. Cerebrum, spinal cord, brainstem. That doesn't logically flow because the brainstem is above the spinal cord. Spinal cord, brainstem, cerebrum. No. Cerebrum, brainstem, spinal cord. That logically flows the order in which the structures of the brain flow. All right, and this picture is just there showing that your ascending and descending tracts and how they cross over. So here, these nerve fibers cross over here. These red nerve fibers are crossing over here down towards the base of the spinal cord. And these orange nerve fibers are actually crossing over higher up, more in the medulla oblongata. All right, just a summary slide of the different tracts and what they do. All right, ALS, amyotrophic lateral sclerosis, also called Lou Gehrig's disease. This was that ice bucket challenge several years ago. Basically, it's a degeneration of your motor neurons in your spinal cord, brainstem, cerebral cortex. It's going to start out more towards your feet and kind of work its way up. Basically, you have some overactive microglia. That's part of your central nervous system, neuroglia. Your supporting structures, basically, they're going to kill your neurons. And your astrocytes can't counteract. Speaking difficulties, dragging your foot, clumsiness, fatigue, coordination issues, muscle twitches, and limb weakness. Basically, it doesn't affect your brain at all. Your cognitive function usually remains normal. As this disease works its way up, it's going to paralyze your respiratory system, and typically these people are going to be put on a ventilator, and after that, they usually have about a 2 to 5 year lifespan. There is no cure for ALS. Remember, this is a central nervous system disease, and we can't regenerate central nervous system neurons. All right, spinal cord injuries. Very common in the workplace, motor vehicle accidents, and the severity depends on the extent of and location of the damage. So the higher the damage of the spinal cord, the more physical limitations you're going to have. There's a saying out there, C3, C4, C5 keeps the diaphragm alive. So if you sever your C3, C4, or C5 at the spinal cord level, you're not going to be able to breathe because your C3, C4, C5 innervates that phrenic nerve, which is going to innervate your diaphragm to keep you breathing. Remember that central nervous system neurons don't regenerate. And remember that those ascending tracts, if you injure your ascending tracts, you can lose sensation. Injury to those descending tracts can lose motor function, including being paralyzed. All right, central nervous system. We have the peripheral nervous system that connects the central nervous system to everything else. Cranial nerves arise from the brain, so they are not part of the brain. Spinal nerves arise from the spinal cord. They are not part of the spinal cord. And your peripheral nerves are all part of your peripheral nervous system. Remember, we can divide the peripheral nervous system into the somatic nervous system and the autonomic nervous system. The somatic nervous system controls our conscious activities, so those cranial nerves and spinal nerves that connect to the skin and skeletal muscles. Your autonomic nervous system are the cranial nerves and spinal nerves that connect that central nervous system to our insides, like our viscera and our glands, our unconscious or subconscious activities that we're not aware of. All right, summary slide. Oops. All right, so kind of the structure of a nerve. We've kind of looked at this already. Just like the muscles, the nerves have 3 different connective tissue layers. the epineurium, perineurium, and the endoneurium, depending on what they are surrounding. The epineurium surrounds the nerve as a whole. The perineurium surrounds the fascicles of the nerve, and the endoneurium kind of surrounds individual axons. Now, nerve fiber classifications. Remember that we have cranial nerves that originate from the brain, spinal nerves that originate from the spinal cord. And so far that we've divided nerves as sensory nerves, that, or our afferent nerves that bring impulses into the brain and spinal cord. And that we have motor nerves or efferent nerves that bring impulses from the central nervous system back down to muscles or glands or to those effectors, effectors, which are muscles or glands. However, what we see is that most of the nerves out there are actually mixed nerves, that they contain both sensory components and motor components. Some nerves are sensory only nerves, some nerves are motor only nerves, but most nerves are actually mixed nerves, and that they contain sensory component and motor components. They're a 50-50 split. So when we say that they're a sensory only nerve, it might be 90% sensory but 10% motor. But we'll just say that it's a sensory nerve. When we say that it's a motor nerve, it might be 90% motor, 10% sensory, but we'll say it's a motor nerve only. Mixed nerves are going to be about 50-50 split sensory and motor nerve. All right, so cranial nerves. We have 12 pairs of cranial nerves. We label them from 1 to 12. We use Roman numerals, so you have to know your Roman numerals. Roman numeral 1, 2, 3, and then I'll jump to 5. 5 is the letter V. 4 is 5 minus 1. 6 is 5 plus 1. 7 is 5 plus 2. 8 is 5 plus 3. 10 is X. 9 is 10 minus 1. 11 is X, 10 plus 1, and 12 is X plus 2, or 10 plus 2. So that's how you number cranial nerves. You have to know your Roman numerals. So with cranial nerves, some are sensory only, like there's no motor component to your sense of smell. Some are motor only, and we say primarily motor because it's 90% motor, 10% sensory, but we're going to say motor only. And some are going to be mixed nerves. Actually, most are going to be mixed nerves. Most are going to be attached to the brainstem, with the exception of the first 2 pairs of cranial nerves. Your olfactory nerve is the first cranial nerve, and that's going to start in the nasal cavity. Your optic nerve, which is cranial nerve number 2, that originates in the eyes. But the rest are going to be attached to the brainstem. So here are pictures of the cranial nerves. For classroom purposes, you're not going to have to know where they are attached. Cranial nerve number 1, your olfactory nerve. Cranial nerve number 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So you're going to have to know the Roman numerals, the names. All right, so for here, I'm just going to gloss over this and then I'll tell you what you need to know. So just kind of hang on, I'll tell you exactly what you need to know. Cranial nerve number 1, olfactory nerve, sensory nerve only, sense of smell. Cranial nerve number 2, optic nerve, sensory nerve only, optic, eyes, vision. Cranial nerve number 3, ocular motor nerve. So it's primarily motor. So motor, moving your eyelids. Cranial nerve number 4, trochlear nerve. It's a motor nerve. Helps move the eyes. Cranial nerve number 5, that's your trigeminal nerve. It's a mixed nerve, contains both sensory and motor components. You don't have to know all of these divisions. Muscles of mastication. Mastication just means to chew. So a lot of your chewing muscles. Cranial nerve number 6, abducens, primarily motor. Eye movement. Facial nerve, cranial nerve number 7. It's a mixed nerve. A lot of your taste receptors and facial expressions. Cranial nerve number 8, vestibulocochlear nerve. It used to be called the acoustic nerve or auditory nerve. It's a sensory nerve only. Has 2 branches, the vestibular branch and the cochlear branch, hence the name vestibulocochlear nerve. Glossopharyngeal nerve, cranial nerve number 9. It's a mixed nerve. So gloss means tongue, pharyngeal means throat. So a lot of your pharynx, tonsils, part of your tongue, salivary glands. Cranial nerve number 10, probably the vagus nerve, probably the most important nerve in your body. Pharynx, speech, swallowing, impulses to your heart, visceral organs, thorax, abdomen, sensory for your throat, esophagus, visceral, thorax, abdomen. Accessory nerve, cranial nerve number 11, used to be called spinal accessory nerve, motor nerve. Cranial nerve number 12, hypoglossal. It's a motor nerve. Hypo means under, glossal means tongue. So under the tongue, muscle. Speaking, chewing, swallowing. All right, so what do you need to know? You need to know the Roman numerals. You need to know the names. You have to know whether it's sensory, motor, or mixed. Now, there is, I'm going to go back up to, I'll go here. There's a saying out there to determine whether or not it's a sensory, motor, or mixed. And when I say mixed, I'm going to say both. I'm going to use sensory is X, motor is M, and mixed will be B for like both. So some say marry money, but my brother says big brains matter more. So some say marry money, but my brother says big brains matter more. That's how you remember if it's a sensory nerve, a motor nerve, or if it's both, if it's a mixed nerve. Now, you can come up with your own way to remember whether or not or how to remember the names of of the cranial nerves. And in Canvas, I posted a document that you should probably look at. It gives you a mnemonic of how to remember the cranial nerves. There's 3 out there. One is on old Olympus's towering top, a Finn and German viewed some hops. That's just one out there. But however you want to remember them is fine with me. All right. So what cranial nerves are comprised of only sensory fibers? So some say Mary Money, but my brother. Facial nerve. That's a mixed nerve, so that one's out. Answer B, that's a sensory. Some say Mary Money, but my brother says that's a sensory, so this one would be your answer. Motor. Which one of these are motor nerves? That's a motor nerve. This one's a motor nerve. This one's a motor nerve, so that's going to be your answer. All right, I actually already kind of went through this slide already for labeling the cranial nerves. Or for your spinal nerves. Spinal nerves, all your spinal nerves are going to be mixed nerves. We've already talked about the cauda equina that extends beyond the tip of the spinal cord. So no need to go back through this one again. All right, dermatomes. So dermatomes are your sensory component, and each spinal nerve corresponds to a specific area of the skin. So if I'm having an issue with this area of my skin, I can correlate that to I might be having an area with my L3 spinal nerve. If I'm having an issue with my nipple area, I could be having an issue with my T4 spinal nerve. The example here, if I'm having an issue with this area of my neck here, my C3 spinal nerve might be involved. So we look at this, if I'm having numbness and tingling down one side of my leg, I might have a herniated disc. So remember that this is sensory, not motor. So dermatomes are sensory component only, not a motor component. All right, and we kind of already talked about this when we talked about our reflex pathway, that posterior dorsal root ganglion contains cell bodies of sensory neurons, and that the axons of sensory neurons are found in that posterior root, and that anterior root contains axons of motor neurons. So that receptor goes into that afferent sensory neuron, and that it goes through that posterior root, and that posterior horn of the spinal cord connects up with that interneuron, and that goes into the motor or that efferent neuron out through the anterior root. All right, spinal nerves. Remember that the spinal nerves are mixed nerves. All right, we also have these things called nerve plexuses. We find these in, we have 3 of them, a cervical, brachial, and a lumbar sacral. We find these nerve plexuses like in cervical, the cervical branch, remember I said C3, C4 keeps, C5 keeps the diaphragm alive. It innervates that phrenic nerve, which then innervates that diaphragm. So the cervical plexus actually is C1 to C4, and basically supplies or innervates those muscles in the head or of the neck and skin. Your brachial plexus actually is C5, C6, C7, C8, and T1. And these nerves will actually join together, come apart, join together, come apart, and they eventually will form the musculocutaneous nerve, your ulnar median nerve, your radial nerve, your axillary nerve. And you're going to need to know that your ulnar nerve supplies the muscles of the forearm, hands, and then the skin of the hands. So remember the ulnar nerve. So after breaking her forearm, Riley lost motor function, feeling in her fourth and fifth phalanges, as well as that side of her hand. What nerve has she damaged? I just told you the answer. That's your ulnar nerve. That's the only one you're going to have to remember. All right, your lumbar plexus, that's your L1 through S4. So a lot of your lumbar sacral nerves form this lumbar plexus. And it's eventually going to become your obturator, femoral, and your sciatic nerves. So if you ever heard of sciatica, sciatica, pinched sciatic nerve, very, very, very painful. All right, spinal nerve injuries can be caused by coming through the birth canal. Dislocations, vertebral fractures, stabs, gunshot wounds, pressure from tumors, whiplash from a car crash where your head just kind of beats back and forth, bending of the neck, compression of that cervical plexus. Remember C1 to C4. You could have a persistent headache or neck pain. You can dislocate that vertebrae, leading to damaged axons. If you damage that C3, C4, C5, remember that can lead to diaphragm paralysis. We're not going to talk about thoracic outlet syndrome. We talked about sciatica already. Pain in the lower back, your butt, thigh, calf, foot, very painful. All right, autonomic nervous system. Part of your peripheral nervous system. Autonomic, your automatic functions without conscious effort. It controls your visceral activities like your smooth muscle, cardiac muscle, your glands. Everything goes back to homeostasis. Responds to stress, helps prepare for exercise, intense physical activity. We can divide this into your sympathetic and your parasympathetic activity. And that your I think I skipped a slide on. I skipped several slides on mine. Oops, sorry. All right. Some general characteristics. Remember that the hypothalamus exerts control over the autonomic nervous system. All of our negative feedback loops. Remember that we have those reflexes. Your afferent fibers transmit from the internal organs to that central nervous system. And then we have those efferent pathways that are going to go back to through those ganglia, which we'll talk about here in a few minutes, outside of the central nervous system to act on those effectors which are muscles or glands. And in response, those nerves will either contract skeletal muscles, they're going to secrete something, or we can inhibit skeletal muscle movement, or we're going to inhibit the gland from, or we're going to stop the gland from secreting something. All right, if you remember, we have two divisions of the autonomic nervous system. We have the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system, I guess I should have answered your slide. Sympathetic nervous system prepares the body for fight or flight situations, so adrenaline pumping situations. Stressful situations, emergency situations, situations that require energy. And two of the chemicals that are released or activated under the sympathetic nervous system is epinephrine and norepinephrine, which are we call epinephrine the same thing as adrenaline. So you get an adrenaline rush. That is epinephrine. Norepinephrine is called noradrenaline. And both of these chemicals, we actually call those catecholamines. Both of these chemicals are released by the adrenal medulla. The adrenal medulla is a gland that sits on top of the kidney. So we could say functionally, the adrenal medulla has the same effect on the body as the sympathetic nervous system. So they're kind of pretty much the same thing. The adrenal medulla is kind of equal to the sympathetic nervous system. The parasympathetic nervous system prepares the body for kind of rest or digest activities. And we see this under non-stressful conditions. And most organs receive input from both divisions. However, one of those systems, the sympathetic or parasympathetic, kind of takes control. So what I do is I say, think of meeting the bear in the middle of the woods. And now look at each organ system. After you crap your pants, what do you think would happen with that organ system? And that'll let you know if that's going to be a sympathetic or parasympathetic primary. So let's look at the cardiovascular system. If you meet the bear in the middle of the woods, your heart rate's going to increase. Your blood pressure is going to increase. So therefore, your cardiovascular system is going to be sympathetic primary, or your sympathetic nervous system is going to be primary with the cardiovascular system, even though there are some parasympathetic innervation to your cardiovascular system. What about your digestive system? You meet the bear in the middle of the woods. Your body really doesn't care about digesting carbohydrates or proteins when you meet the bear in the middle of the woods. So therefore, your digestive system is going to be primarily under parasympathetic control, even though there is some sympathetic nervous system stimulation to your digestive system, but parasympathetic primary. Now, urinary system. What happens with your urinary system, your kidneys, your urinary bladder. Most people would think that your body doesn't really care about producing urine during meeting the bear in the middle of the woods. However, go back to what we just said about the sympathetic nervous system. We release epinephrine, norepinephrine. The adrenal medulla is what secretes those things. The adrenal medulla sits on top of the kidneys. So therefore, your urinary system doesn't only produce urine, but it produces epinephrine and norepinephrine. So the urinary system falls under sympathetic nervous system stimulation as its primary. All right. So most organs receive input from both divisions. All right, so during exercise, what part of the nervous system inhibits digestion and increases heart rate? So inhibiting digestion. So the easy one is increases heart rate. Increases heart rate would obviously be the sympathetic nervous system. You meet the bear in the middle of the woods, your heart rate goes up, that's your sympathetic nervous system. So this one is kind of like a backwards answer, inhibiting digestion. That is, remember, parasympathetic control would be rest or digest. But if we flip-flop that answer, so inhibiting digestion would be the reverse of parasympathetic control, which would be your sympathetic nervous system. All right, so we can look at neurons of the autonomic nervous system, or the autonomic nervous system. Those motor neurons, remember, those are your efferent neurons. When we look at those neurons, remember that we have that term ganglia, and that's a cluster of neuronal cell bodies located in the peripheral nervous system. When we look at those motor neurons, we'll see when we have two neurons that link up, they're going to link up in a ganglion. And so when we draw neurons, remember we draw neurons with that cell body and that axon, and then they're going to link up in that ganglia. And then we have another neuron cell body and then the axon. So we could say we have a preganglionic neuron, or we could say a preganglionic fiber. That would be number one. And then we could have a postganglionic neuron, or we could say a postganglionic fiber. So the preganglionic fiber, those neuronal cell bodies are actually in the central nervous system. Then they leave the central nervous system and they're going to synapse in some sort of ganglion. Then those postsynaptic neurons, their neuronal cell bodies are inside the ganglia, and that they are going to extend, they're going to terminate on their target organ, or that skeletal muscle, or that muscle, or that gland. So here we would just say that they're going to terminate somewhere on that target organ, that effector. And that effector, like I said, is going to be a muscle or a gland. So that preganglionic fiber originates in the central nervous system. It goes to the ganglia, where it links up or synapses with a postganglionic fiber inside that ganglia. And that postganglionic fiber then goes to that target organ, that muscle or gland. Now, when we look at the sympathetic nervous system and the parasympathetic nervous system, they both act in the same way. So here, remember that if we look at the autonomic pathway, our visceral pathway, we can see that on the motor side, because remember we're dealing with the motor component, that motor side is going to leave that anterior root, and that preganglionic fiber originates in that central nervous system. Remember that central nervous system inside that horn of the gray matter of the spinal cord. And then it's going to link up with that postsynaptic fiber or that postganglionic fiber inside that ganglia, and then eventually it's going to go to its target organ, and then in this case it looks like a portion of the intestine, and then our effector is going to be the intestine. With the somatic pathway, remember that's our pathway that has some sort of voluntary control. The we will we typically don't see that nerve fiber link up into a ganglia because we're talking about the autonomic nervous system. We're only talking about the sympathetic and the parasympathetic nervous system. So this somatic pathway, we don't see that pre-ganglionic fiber and that post-ganglionic fiber. This is where we have our 5 components: our receptor, our afferent neuron, our interneuron, our efferent neuron, and our effector. So only on the autonomic side will we see that linkage between the preganglionic and the postganglionic fiber link up in that ganglia or that ganglion. All right, so now we need to differentiate between what happens in the sympathetic side versus the parasympathetic side. So I'm actually going to kind of skip the next several slides and kind of I'm just going to kind of draw my own stuff. All right, so when we're looking at the sympathetic nervous system, I'll do sympathetic nervous system over here, and I'll do the parasympathetic nervous system over here. So the sympathetic nervous system, that's going to be our nerve fibers that originate off of T1 to L2. And remember that our spinal cord ends around that L1 to L2 space. So that's why we only go down to L2. So basically all of our thoracics and the first 2 of our lumbar vertebrae. Spinal nerves. So now we're talking about spinal nerves. And if we look at the anatomy of the spinal cord and what's kind of nearby the spinal cord, we'll see that, let's say that we have the spinal cord right here. What we see is that we have a cluster of these ganglia that lie right near the spinal cord. And that's called the paravertebral ganglia. They lie right next to the spinal cord. They go all the way down from T1 to L2. All right, so far so good. So if we're looking at, and remember, we're talking about the autonomic nervous system, or more specifically, the sympathetic division of the autonomic nervous system. So we could actually look at the links of the preganglionic fibers and the postganglionic fibers. So here, if we're looking at the length of the preganglionic fibers, really all we're doing is going from the spinal cord to that paravertebral ganglia. Para means side or near. So these paravertebral ganglia lie very near to the spinal cord. So if we're drawing our nerves, and then we would have, some sort of target organ kind of way down here. So then we would have another nerve, our postganglionic fiber, that would be kind of way down here. So if we draw our preganglionic fiber, it would be very short because all we're doing is going from the spinal cord to that paravertebral ganglion. And then our second nerve fiber would actually be very long because we're going from the paravertebral ganglia down to that target organ. So that's one scenario on the sympathetic nervous system side. The other scenario that we see on the sympathetic nervous system side is that instead of having these paravertebral ganglia, let's say that we still have our target organ here, is that we have these ganglia that are about halfway in between the spinal cord and that target organ. So if it's about halfway in between, we would have a neuron, our preganglionic neuron, and our postganglionic neuron. That's roughly about the same size. Does that make sense? All right. So that is the sympathetic side. Now, on the parasympathetic nervous system side, we don't have, well, I guess first I'll say on the parasympathetic side, we have the, our neurons originate either in the brainstem as well as S2 to S4, our brainstem, and then our S2 to S4, so our sacral region of our spinal nerves. And what we see is on the parasympathetic side, we don't have any paravertebral ganglia, but we still have ganglia. Now, we still have our target organ. We still have our spinal cord. But what we find is that the ganglia for the parasympathetic side lie either one of two places. They're either very near that target organ. So that's our first scenario. They lie near that target organ. And in that case, we would have a very long preganglionic fiber and a very short postganglionic fiber. So we'll draw that one. A very long preganglionic fiber and a very short postganglionic fiber to get to our target organ. Or that ganglia would actually be on top of that target organ. So we would have a very, very long preganglionic fiber, and then a much shorter postganglionic fiber. To get to our target organ. And remember, our target organ for the autonomic nervous system is going to be our visceral organs, things that we don't have control over. Smooth muscle, cardiac muscle, all of our glands. We are not talking about skeletal muscle here. Skeletal muscle falls under the somatic nervous system. So we're not talking about the somatic nervous system. We're only talking about the autonomic nervous system here. All right. So on the sympathetic side, remember we have in option 1, we have those paravertebral ganglia. So we're going to originate in the spinal cord. Our preganglionic fiber originates in the spinal cord and goes from the spinal cord to that paravertebral ganglia. And then we're going to go, then our postganglionic fiber goes from the paravertebral ganglia down to our target organ. So we're going to have a short pre and a long post. That's option 1. Option 2 is where that ganglia is about halfway between the spinal cord and the target organ. So we're going to have about a 50-50 size of our pre and our post. For the parasympathetic nervous system, we don't have any paravertebral ganglia. Remember, those ganglia lie near our target organ or directly on top of our target organ. So from the spinal cord or the brainstem, our brainstem or S2 to S4, we're going to have a very long preganglionic fiber and a very short postganglionic fiber. All right, so just some of the slides that I skipped over. We have our sympathetic nervous system. So here's our spinal cord. And then we have these paravertebral ganglia. So we would have a preganglionic fiber that would come here. And then we would have a postganglionic fiber that would go to our target organ. Or option 2 is that we would have a preganglionic fiber that goes about halfway, and then we would have another postganglionic fiber that would go to our target organ. Let me find it. So just looking at looking at the sympathetic side, here is our paravertebral ganglia over here. So we would have remember paravertebral, our sympathetic side is T1 to L2. So we would have a very short preganglionic fiber and then a very long postganglionic fiber. Or we would have something about halfway, and then it would continue going on to our target organ. Down here, a very short pre and a very long post, or something that's about 50-50. On the parasympathetic side, we don't have those paravertebral ganglia. So we're going to have, remember, those ganglia lie either near the target organ or on that target organ. Near or on those target organs. So we're going to have a very long preganglionic fiber and a very short postganglionic fiber. And remember, those originate in the brain stem and S2 to S4. All right, so let me do this. All right, so where am I? Here I am. So let me go back to sympathetic nervous system and parasympathetic nervous system. So on our sympathetic nervous system, we have a very short preganglionic and a very long postganglionic, or I'll draw my cell body a little bit bigger, or we have about a 50-50 split. And on the parasympathetic side, we have a very long pre and a very short post to reach our target organ, or we have an even longer pre and an even shorter post to act on our target organ. All right, now, remember that we have 100 different neurotransmitters. And remember that, acetylcholine is responsible for skeletal muscle contraction. We talked about that a couple chapters ago. Anytime a neuron synapses with another neuron, acetylcholine will be the neurotransmitter. So here in our ganglia, we have acetylcholine being released on the sympathetic side and the parasympathetic side. Because a neuron to a neuron always releases acetylcholine. Anytime that we have a parasympathetic postganglionic fiber, that will also release acetylcholine. So you can just kind of make a blanket statement that says anything that is parasympathetic will release acetylcholine. Anything that releases acetylcholine, we call those cholinergic neurons. So here we actually have a total of 6 cholinergic neurons. 1, 2, 3, 4, 5, and 6. So anytime neuron to neuron releases acetylcholine, and then your parasympathetic postganglionic fibers release acetylcholine. Now, on the sympathetic side, your postganglionic nerve fibers do not release acetylcholine. We go back up to this slide. Let me find it up here. Functionally, the adrenal medulla has the same effects as a sympathetic nervous system. The adrenal medulla secretes epinephrine and norepinephrine. So we have to choose, does the sympathetic postganglionic fiber secrete epinephrine or norepinephrine? Actually, it's going to be norepinephrine. We actually find that postganglionic sympathetic nerve fibers release norepinephrine. So anytime anything releases norepinephrine, we call those adrenergic neurons. So adrenergic neurons release norepinephrine, also called noradrenaline. So all of your postganglionic sympathetic nerve fibers release norepinephrine. All right, so this is kind of what I just drew. On the parasympathetic side, we have long pre's and short posts, because that ganglia is either near the target organ or on the target organ. Anytime we have a neuron connecting with another neuron, it releases acetylcholine. And then remember that parasympathetic nerve fibers always secrete acetylcholine as a neurotransmitter. Remember the parasympathetic side, brainstem, S2 to S4. On the sympathetic side, we have those paravertebral ganglia. And then we also have ganglia that are halfway between the spinal cord and the target organ. So we're going to have either a short pre and a long post, or we're going to have about a 50-50. Again, anytime a neuron synapses with another neuron, acetylcholine. Your postganglionic fibers of the sympathetic nervous system release norepinephrine. Those are adrenergic neurons. T1 to L2, so your 12 thoracics and your first two lumbars. So T1 to L2 are your sympathetic spinal nerves. All right, again, most organs are innervated by both the sympathetic and parasympathetic nervous system. However, they both do, they are opposites of each other. All right, so I talked about cholinergic receptors. Acetylcholine binds to cholinergic receptors. We can classify these cholinergic receptors as either muscarinic or nicotinic receptors. Muscarinic receptors, they're excitatory. They're a little bit slow, and they can be activated by this fungal toxin called muscarine. Atropine also binds to these muscarinic receptors, and they can actually block the action of acetylcholine. Atropine is, we give that for a slow heart rate, We can give it in code situations. Nicotinic receptors, they're excitatory as well. They're not as slow. If you smoke, that would actually bind to your nicotinic receptors, and that's why you get a buzz while you are smoking. You take the first drag of cigarettes every day, and it's because that binding, because that nicotine binds to those cholinergic receptors. Adrenergic receptors. Remember the norepinephrine that is secreted by those postganglionic fibers of the sympathetic nervous system. Both epinephrine and norepinephrine can bind to those adrenergic receptors. We have several different types of adrenergic receptors. We have alpha 1, alpha 2, beta 1, beta 2, beta 3 receptors. And those basically, they're going to elicit different responses on those various receptors. If you're going to nursing school or med school, you're going to have to become very intimate with the difference between alpha 1, alpha 2, beta 1, beta 2, beta 3. If you're in, when we get to the lab, I'll show you a slide about the difference between alphas and betas. All right, so we know that once we release that neurotransmitter, somehow that neurotransmitter has to be removed out of that synaptic cleft. We already know that acetylcholinesterase decomposes or gets rid of acetylcholine from those cholinergic fibers. Norepinephrine from those adrenergic fibers gets taken back up into that synapse, or taken back up into vesicles into that synaptic knob by active transport. It's actually inactivated by this enzyme called monoamine oxidase. You just have to be careful. We have those, I've talked about them before, monoamine oxidase inhibitors. It's a classification of medication that we really don't use too much anymore, but some people still take them. All right, so control of the autonomic activity, so your automatic functions. Remember, I've said this numerous times already, controlled by the hypothalamus. This is all negative feedback loops. So controlled by the autonomic nervous system. These are your involuntary activities. Medulla oblongata, cardiac, vasomotor, respiratory activities. Hypothalamus regulates a lot of your visceral functions, body temperature, hunger, thirst, water, electrolyte balances. A lot of your reflexes occur in your medulla oblongata and your spinal cord. That's why I made the joke earlier about if you want to take someone out, get them in the pons, medulla. A lot of your reflexes in the medulla, cardiac, vasomotor, respiratory activity. Remember that your limbic system, your cerebral cortex, a lot of your emotional responses, a lot of your emotional expresses come from that limbic system. All right, lifespan changes. Your brain cells actually begin to die before birth. Remember we talked about apoptosis, that natural programmed cell death. Over your lifetime, your brain mass shrinks about 10%. More gray matter is lost than white matter due to aging. Remember, 75% of your neuronal cell bodies lie in that cerebral cortex, that outer layer of your cerebrum. Many cells die in your temporal lobes, but few in your brainstem. By about age 90, your frontal cortex has lost about half of its neurons. We lose a lot of our neurotransmitters. Your action potentials, that propagation decreases by about 5 to 10%. So your reflexes become slower. Our memory starts to fade. We have slower responses, slower reflexes. We have an increased risk of fainting or falling. We have changes in sleep patterns. As you get older, we require fewer hours of sleep. We actually really only need about 6 hours of sleep as we get older. All right, so that's all I have for chapter 11. So let me know what questions you have. Otherwise, I will see you next chapter. All right, take care.